Today, I'm excited to share with you something I've been working on, and it's a variety show of sorts. A little bit of education, some fun, podcasts, like all the stuff that you love to listen to, all mixed into one. And I invited 3 of my good friends who are wonderful educators to be part of it. So I really hope you enjoy what I'm calling Morning Report. Welcome to Morning Report. This is our brand new show that we're doing where I don't really know what type of show this is, but it's going to be fun. My name is Haney Malamat. You know me from social media, Critical Care Now, but I am really lucky to have with me today 3 guests who are super smart and pretty entertaining. So let me bring them on. The first one is Dr. Steve Haywood. What's up, my man? Your name is not Anand Swaminathan. That is your name right there, Steve Haywood. Hey, Steve MD. We got Anand Swaminathan, the Swami from MRAP. What's going on, my man?
What's up? How's it going?
Good, man. Good to see you. And we have Mike Carunchio from Delaware and Cooper EMS. Is it okay to say where you work and all that stuff? Your employer's not going to get mad? Or do you just not care?
I mean, you work there too, so they're going to take us both down. So
That's fair. That's fair. Well, it's good to have all of you on today. How's everyone's week been going?
Good, man. Looking forward to this.
Yeah. All right, cool. And Swami was really kind enough to provide us with the case. The ethos of what the show is really is to get to like morning report, the traditional morning report that we usually know, where we go over a case and then do just a little bit of discussion afterwards. So Swami, why don't you kick us off?
Yeah. Diagnostic mystery. When I did morning report as a resident, I always like them to be kind of straightforward, but maybe some nuances in management. So I have about 7:30 in the morning. I get a call from EMS that they are going to be bringing in a patient who they said looks pretty sick. And I will tell you that my paramedics, this is a prior job, they were absolutely the best. And so when they have like a little anxiety in their voice, I get a little bit of anxiety as well. So the patient rolls in, and it was a 52-year-old woman who was coming from a rehab center. She had had a tib-fib ankle fracture dislocation, had it fixed, and then was in rehab, basically getting her strength back, etc. And they basically woke her up. She got up, had breakfast, and then was going to do therapy when she had a syncopal event. They called EMS. EMS arrives, and her pressure was about 70 on 40. She looked a little pale. She was a little hypoxemic in like the mid 70s. She was tachycardic. So they grabbed her, threw her in the ambulance, and started rolling towards us. So, we had a couple of minutes before she hit the door, and we're getting things together. She rolls in, and, this lady's got a big cast on her right lower extremity where she had this tib-fib ankle fracture dislocation, or maybe it's like an immobilizer that she's got on there. And right away, you look at the vital signs. She's hypotensive. She's hypoxemic. She's tachycardic. I think this is a PE, right? I mean, like rolling in, I'm like, this lady has a pulmonary embolism. That's what I'm thinking right off the bat. And so, like I said, the diagnosis wasn't really a mystery. It was a matter of what we're going to do in terms of management. So we got this lady in front of us. I don't have a definitive diagnosis, but we bring our ultrasound in. We're getting a line. We're getting labs off. So let me ask you guys, what's your first move in fixing this patient? And I will tell you that she was pretty tachypnic. Like she was in the 30s. She was speaking in like 1 or 2 word sentences. Would you be moving to intubate her? Are you going to give her respiratory support? If so, what are you going to give her respiratory support with? And what are you starting in terms of her pressure?
So you did an echo already? Did I hear echo?
Yeah. So, we slapped an ultrasound on while we were getting an IV. And this was, again, not a big mystery. Her right ventricle was huge. Her left ventricle was a bit on the small side. There was no effusion. Now, Steve, I did use my stethoscope and I listened to her lungs. Her lungs were clear. All right.
Okay,
I did do that as well.
Clear
lungs.
Yeah. I saw one of those too. Occasionally it gets busted out.
I mean, it's usually just there like for window dressing, but I actually used it.
Sure. Yeah.
So she's got a big right ventricle. She's got a small left ventricle. She's got clear lungs. She's got no pericardial effusion. So, I mean, pushing us more to PE.
Perfect. I think that I love this case and I love the question that you asked because we hear hypoxemia. I can't get oxygen in them. I've got an underbreather. I can't get their stat up. Let's escalate to intubate, which works for like ARDS, pneumonia, works for, lung pathologies. Here, this is not a ventilation issue. This is presumably a perfusion issue. So more pressure, I don't know what other pathologies this patient has, but I'm not going to recruit a lot of extra alveoli with positive pressure to fix my SAT. And what I'm going to do if I jump to that is I'm going to add a lot of afterload onto my right ventricle that for my echo is already struggling. So as far as respiratory support, I'm staying where I'm at. Non-rebreather is a great device. I can deploy quickly. Maybe I'll get a hyponasal occasionally if I think I'm going to be on that high FiO2 for quite a while, but I'm going to try to avoid positive pressure as much as possible.
Mike, let me ask you a question because, this patient did have some pre-hospital time.
Sure.
Although in our spot, this rehab center is like literally down the block around the corner. So we knew that they were not going to give us much time. They were not going to have much time in the field. But if you had a longer transport, what were the things that you'd be thinking of? And I'll tell you, this patient rolled in. They were like, we tried to start an IV. We couldn't get one. I'm like, it's fine. You were in the ambulance for 4 minutes. Don't worry about it. But
Sure.
If you had like a 15 or a 20 minute, what would you be doing with this patient?
Yeah, well, first off, I would not want to intubate her. Let me just say that hands down. I think the last thing I would want to initially do is push a paralytic on this lady and then increase her intrathoracic pressure with ET tube. Just like you said, you wouldn't do positive pressure ventilation. I think the first thing first would be to identify that she's having the problem. I think the leg immobilizer, the tachycardia, the hypotension, and the hypoxia are real big. Second is going to be oxygenation. Steve said non-rebreather mask. That was the first thing I was thinking. We generally have CPAP. Some programs have BiPAP. I don't necessarily think that would work because it's a VQ mismatch problem. So I would want to maximize her oxygenation. I would throw a non-rebreather on, but I wouldn't expect to do a whole lot. And then for the hypotension, I don't want to overtax that right ventricle that I suspect is struggling to function. But she needs something. So I would probably do a judicious fluid bolus. I'd probably start at like 250 and then reevaluate. And then I'd probably have some pressors ready to roll if she didn't improve with a little fluid bolus or two. Luckily, where I work full time as a ground medic, not on the helicopter with Haney, we have Levofed, we have epinephrine. So we have a couple of good choices. I know a lot of EMS programs have dopamine, which is because the medical directors have not retired yet and they're still like 86 years old. But we are lucky in Pennsylvania to have Levo and Epi as an option. So that's kind of what I would be thinking. But I wouldn't expect her to get much better during the transport. So yeah. I would be highly anticipating this person to crash.
Mike, you're super smart and you have really good clinical instincts. And I'm only saying that because you're here on the show, not because I believe that. But
thanks.
But I mean, in all seriousness, it's reasonable to assume though that someone with less experience than you and less clinical sense than you would see a hypotensive patient short of breath and make that decision. So being that there's going to be some pre-hospital folks that listen to this, what insights can you give them into saying like, yeah, it could seem like somebody who's septic and maybe they have a pneumonia, but here are the reasons why I wouldn't do those things pre-hospital.
Well, sure. I think the foundation, I don't know if this is going to answer your question, but this is what I want to talk about. So I'm going to say it. No, I'm kidding. But I think this will kind of answer the question. Paramedic education is taught in modular format, which has its benefits. You can get a lot of information out in a very efficient period of time, but it silos your thinking. And PE is typically put in the pulmonology section of paramedic training. Go figure. It's ultimately a lung problem. So everybody focuses on the VQ mismatch, the shortness of breath, but paramedic education does a really crappy job of teaching that patients die because of PE because of right ventricular collapse or dysfunction. You may see a little sentence like right ventricular strain, but then they don't train you what that is. So I always train my students to have a high degree of suspicion, like the leg immobilizer. I mean, that's a smack you in the face thing, but unexplained tachycardia, hypotension, that should clue you into PE. Sepsis is another thing, especially if she had an orthopedic procedure, but is she hot? Is she toxic appearing? If not, I would be thinking more PE. And then I always train my students that everything we do has a consequence. You know, you can have a benefit, but there's definitely going to be consequences. And I really, when I started, we had just gotten RSI kind of on a national basis. and you sneeze and twitch at the same time, paramedics would RSI you. And thankfully, we're getting away from that paradigm. So I always tell my students, like go less invasive on 95% of your patients, just little itty bitty interventions like a 250 bolus, oxygen therapy. Those can have massive implications for fixing your patient, even in the short term. But I always teach them, resuscitate before you intubate does not mean resuscitate before you intubate. Yes, that patient may ultimately need to be intubated, but in the back of an ambulance, is that an optimal place for this patient? No, we want to maximize their physiology, and we can do that in a 15, 20, 30, 40-minute transport to make them a little bit better for you guys to take over and then make those decisions.
That's awesome.
Great.
I think there's a lot in there, right? So norepinephrine, giving some oxygenation. I'll tell you that we did end up starting this patient on non-invasive, and we had that very quick discussion in our heads about whether giving this patient some positive pressure ventilation was going to drop their preload more and make them worse. But ultimately, I'm like, non-invasive, she's still got to trigger that machine. So there's still a negative pressure aspect to this. So I'm comfortable and trying to give her more oxygen. If I had high flow nasal cannula, maybe I would have tried that. This was actually before we had that readily available. So this is all pre-COVID. I forgot to say that. This is pre-COVID. So COVID was off the table as a diagnosis. So we ended up putting her on non-invasive. We started norepinephrine. Let me ask you guys a question. I think a 250 cc bolus is fine. We all kind of understand we're not going to give a lot of fluids to this patient. It's not like they've been vomiting for 4 days. So we don't think that there is a fluid loss kind of situation. With that norepinephrine, as you are titrating that up, right? And we're doing a lot of things at the same time, but when would you say, not that I'm at the max dose of norepinephrine, but I'm at enough norepinephrine without getting an effect that I'm going to go ahead and add a second pressor? Do you have like a threshold where you're like, okay, at this many mics per kilo per minute, I'm going to add a second vasopressor? Or is it just kind of like, that seems like a lot, I'm just going to add something else in the background?
For PE specifically, I like vasopressin. There is no big RCT that says norepi vasopressors. Vasopressin is the big one. But I don't know if vasopressin is going to spare my pulmonary vasculature more than it will my systemic. And so for PE specifically, very low threshold, norepi I can get on quick. And so I'm usually going quick, roll it with norepi, but I'm usually ordering my vasopressin as soon as I start it. And in my other run-of-the-mill patients, once I hit like 0.1, 0.2 on my norepinephrine and I'm not seeing an effect, I'm going ahead and I'm ordering my vasopressin. It's coming from the pharmacy, so it's going to take a minute. And then the other thing I'm doing, I swear half of my community is adrenally suppressed because everyone loves their Decadron shot every time they get a sinus infection. So once I get about 0.1, 0.2, I'm going with my steroids and I'm ordering my vasopressin. And honestly, a lot of times the steroids are what really kind of gets them out of it.
That's interesting. So I'm much earlier to grab vasopressin, especially in PE now, but I don't think I understood that at that time. So we ratcheted up to, I think we were at about 0.3, and the nurse was like, I can keep going up, but do you want to add something else? So it was actually a prompt from one of my nursing colleagues asking me for something else. And so we threw vasopressin on it. And now I think I have a better understanding that this can cause a little bit of that pulmonary vasculature dilation. So might be giving you a little bit more benefit by giving that vasopressin. So we had the norepi on, we had the vasopressin on. The blood pressure still wasn't great, but it was maybe a little bit better. Her oxygenation was maybe a little bit better. And so the next thing that kind of we were thinking about is like, I got to dilate this pulmonary vasculature. And of course, we're talking about thrombolytics, systemic thrombolytics at this point as well. So Haney, Steve, Mike, what are you guys doing if you're looking at a patient like this and you're like, I got to do some pulmonary vasodilation in addition to the fact that I'm giving systemic vasoconstriction with my agents? Is there something that you guys are reaching for at this point?
Yeah, I mean, the one thing I will say that, to go back to the last point is that if slam dunk that this person has a PE, like you're so confident of it, you're confident in your echo skills and this person obviously is not stable to go to CT to confirm that at this point, then vaso is a great option, like we said, because it's just hemodynamically neutral when it comes to the pulmonary artery vasculature. But if that RV is really dilated, people should consider putting on some sort of inotropy. And for me, epinephrine is a great inotrope in this situation. Lower doses get you more inotropy versus higher doses, which get you the vasopressor action. But as you're adding on that second vasopressor, I would ask the question as to whether or not that person really needs a little bit of squeeze for that RV to overcome that resistance in the pulmonary vasculature. And then when it
Let me
comes
ask you a
to,
follow-up with that,
yeah,
Andy,
go ahead.
because like this patient was tachycardic.
Yeah.
And we talk about this pretty frequently when we think about
Yeah.
epinephrine, right? I mean, I think the common situation, and I'm sure Mike runs into this too, is you have that patient with anaphylaxis and they're tachy to like 140, and somebody is going to ask you, are you sure you want to give epi? Aren't you going to make that 140 like 240? So this patient, she's got, I mean, I grant you that we do not have a definitive diagnosis. It's not like when I echoed her, I saw clot in transit, but we're pretty sure we got a PE. And she's tachycardic. Let's say she's like in the 130s. By giving her epinephrine, am I going to speed that heart rate up more? And
Yes.
and not just that the heart rate itself is the danger, but is she going to get even worse LV filling and then forward flow? So do you worry about that in this kind of a patient?
Absolutely. But, all these drugs we're talking about are very short acting. And so you have to do these little experiments at the bedside. This is no different than the person who has atrial fibrillation, let's say, and has sepsis. And you're like, I don't want to start them on norepinephrine because their heart rate's so fast. And what if that beta? The what ifs, I think, are a lot of times what creates a lot of problems in resuscitating patients. Well, what if? Try it and see what happens. And if it does, in fact, lead to that, well, then you can always turn it off. But that person very well could be tachycardic from the fact that they're not perfusing very well. In fact, that's probably the reason why. And so by doing the epinephrine, you're resuscitating that person, and there's a good chance that their heart rate actually come down because now they're better resuscitated, they're getting better oxygenation. But you know what? If you start that epi and their heart rate does shoot up because they are a little bit more beta sensitive, we'll just turn it off and walk away. But these drips that we're talking about in the hospital, and I'm a little soapboxing here, but because this happens every day, even in the ICU. But we have these little debates of like, well, what if this? What if that? It's like these drugs cost like a couple bucks a bag. Hang it up, throw it out if it doesn't work, and keep moving on.
All right, so we're ratcheting up our norepi. We've got our vasopressin on. Maybe we've added epinephrine. Again, well, let's come back to that question of pulmonary vasodilation. Yeah.
I got my soapbox, didn't even answer it.
No, I mean, what are you giving there? Because your norepi and your epi are at least causing some pulmonary vasoconstriction on top of whatever pulmonary vasoconstriction the patient already has. And we talked a lot about oxygenation. If I improve oxygenation, that's a pulmonary vasodilator. If the patient was retaining CO2 and I blow off CO2, that can improve her. But can I give some more agents to really do this as well?
I think the best agent is inhaled nitric oxide. And it's funny because I was doing a grand rounds just a couple months ago for
What a
residency up
flex.
in.
What a
I know.
flex.
Well, it was
I
up
was
in
doing grand
Pennsylvania.
rounds the other day.
Hey,
Go ahead, I'm sorry.
No, you're good. I was talking about this. I was like, inhaled nitric oxide is the best, but it's not practical. You'll never get this in your ER. Somebody's got to pull out the neonatal ICU, and one of the respiratory therapists on there interrupted me. He's like, hey, just so you know, we have the best respiratory therapist in the nation. You call for nitric oxide, I will have it up and going within 15 minutes. It's like, dang, go ahead. But it is the best. It's also the most expensive. There's more setup that goes involved with it. It's such an unstable molecule that you can actually cause some hemoglobinemia if you do it improperly. So for most of us, even though it's the best, we're never going to get it in our emergency.
Mike, you got inhaled nitric oxide on the ambulance?
We have flow lane on the helicopter.
Oh, no way. All right.
Yeah,
All right.
I will tell you that the only times I think I or any of my friends have given it is when it's been started at a sending facility. And with the 25-minute flights that we do in the Philadelphia area, I'd be totally BSing you people if I told you that we're routinely thinking, let's start Flowland. In the ambulance, absolutely not. We don't have it.
I mean, Steve even said, like, his respiratory therapist is telling him they're the best. We'll get it done. It still is going to be 15 minutes. 15 minutes is a long time with a crashing PE patient, right? I mean, like, even in the hospital with all of the resources at my disposal, I'm thinking that this patient's either going to be dead in 10 minutes or we're going to get her better. So 15 is a long time. So I have never in 20 years been able to get nitric oxide at the bedside for a patient. I've called for it, and then I kind of stopped calling for it because I'm like, it ain't going to happen. So I stopped doing that. What other options do I have?
I think, like Mike said, inhaled ibuprostanol is more practical, more available, more likely to get it. But even then, I don't think it's going to happen quickly. Definitely not in my shop. Maybe if you got an ER ICU, you can get it really quick, but that's not something we're routinely starting downstairs. I think it's probably the second best behind inhaled nitric oxide, and it's more practical. I'm probably going to order it because I think I can get it down there quicker, but it still may not be fast enough.
Yeah. Yeah. So in this patient, we kind of thought about those things. I knew I wasn't going to get nitric oxide. We didn't have EPO stocked in the department. And my concern with it not being stocked is not that I can't get it, because in a lot of places that I work, the pharmacy is on the same floor as the emergency room, so I can get it pretty quick. But if my nurses aren't used to using it because we don't have it stocked, then that's going to be its own barrier, right? And again, like, I have fantastic nurses everywhere I've worked, but it's the same thing for me. If I'm not familiar with a medication, it's going to be harder for me to get it going. So we ended up just using inhaled nitroglycerin. And I did not know about this in a prior life, but I learned this from Sarah Krager, that if you take your regular nitroglycerin, shove it into one of those inhaler chambers, like where you put albuterol, and you crank that, the nitroglycerin goes into the lungs, it's converted to nitric oxide. So it's almost like you're giving inhaled nitric oxide, but it's a lot easier to set up. So we did that. We took the big fat albuterol chamber, we filled that thing with nitroglycerin, through the CPAP unit, so that the patient was getting that. And I mean, this is one of those times where it's like, we're doing a lot of stuff, right? So I've got norepi and vasopressin hanging. I gave a little bit of fluids. I started her on CPAP. We started the inhaled nitroglycerin, and the patient got better. And so I'd like to say that it was the nitroglycerin, the inhaled nitro, that did it, but who knows, right? Who knows what it was? But she started to perk up. Like, her pressure was now like 90 systolic, which we liked. It was the first time we were getting a 90 number. And her O2 sat went up to like 94%. So that was like the real big win for us, is that she's oxygenating well. Her pressure's a little better. She looked like she had a little bit more color. She was breathing a little bit slower, but not like the slower, like, now I got to intubate you because you're tiring out. She looked like she was better. And so then it pushed us to, what are we going to do in terms of her next step, right? Am I going to give her systemic thrombolytics? Am I calling, I didn't have a PE response team at the time, but am I calling IR and cardiothoracic surgery? Are they going to take her to the OR and see if they can take something out? Or can I even get a CT scan at this point? Because that was one of the rate limiting steps, is we called all those consultants and they're like, did you get a CT yet? And I'm like, no, because the patient would die if I send her to CT. And so we were still at that point of, I can't get the definitive imaging. And, listen, it's hard for a CT surgeon to crack a chest or to do anything without a CT scan. And I get that. So would you guys give her systemic thrombolytics at this point? Knowing that I've got 2 pressors, I've got inhaled nitroglycerin, I've got CPAP, and I'm finally getting to she looks a little better point.
Yes. And going back to nitroglycerin, yes. I want to soapbox a little bit. It's my turn to soapbox, Andy. No. I love inhaled nitroglycerin, and everyone is scared of it. And they're like, well, we don't know how to do it. We don't know how much to give. The dose recommended in the literature is 5 milligrams over 15 minutes. You're not going to get that much in them.
No.
My nitroglycerin is 100 micrograms per ml. That's what I have in my emergency department. So my dose is keep that going. Just keep it going continuously. They make 200 mics per ml. If that's what you've got, you're still not going to get to that 5 milligram dose. And then they have some 400 mic per ml concentrations. And with that concentration, you will get to that dose of 5 milligrams over 15 minutes. But you're not going to overdose them. You're not going to overdose them. Don't overthink this. Whatever IV nitroglycerin that you have in your shop, get the most concentrated stuff you have and nebulize it and just keep going. Don't think about, how often am I giving this? Am I going to give too much? Just do it. Don't be afraid. Be brave. Be brave.
And then you can't do this by having them sniff the nitro tabs. Like, if you crush those things, you're like, can you snort a little bit of this? Like, that's not going to work, right? Or like take the
snort a line.
Yeah.
That ain't going to work, right? So I agree with you. I put as much in as I possibly can and just keep filling that thing. And this is like one of the themes that comes up again and again. Again, my nurses are great, but once they step out of something that they are used to doing or they've been trained to do, they get a little anxious. Yep. And I get it, because they'll get thrown under the bus. They know that. They've been thrown under the bus before. So I tell them, hey, I'm going to do this. You give me the nitro. I will take care of it. And so when whatever happens, if somebody asks you, you say, I wasn't sure about it, but Dr. Swami grabbed the bottle out of my hand and he gave it to the patient, right? Blame me. I'm totally fine with that. If you're not comfortable, just blame me and move on. And then there's no barrier anymore, right? Everyone's like, all right, as long as I'm not the one who's going to get in trouble. Right. But then they also know I'm not going to throw you under the bus because I told you it's my fault. Document it in your note. Dr. Swami did it. Just point the finger.
Yeah. And I also want to add, remember, these are very short acting drugs. So if you went too far, or if that person surprised their physiology, every once in a while, a patient will do something that they're not supposed to do, right? You just turn it off and it goes away and it's going to be okay. I'm just going to sprinkle in one more thing that I would never do in the emergency department because people don't even use milrinone in the emergency department, but milrinone nebulized also can work the same way. Just for those that are out there, like, what about milrinone? But again, if they're not comfortable nebulizing a drug that they normally use, there's no way they're going to take a drug that they have no idea what it is and start nebulizing it. So just food for thought there.
All right. So I know we have other things that we want to get to. So let's wrap this up a little bit. We're all going to give thrombolytics. Yeah. We all want to do that. We all kind of understand, like, relying on interventional, that takes too long. Even most of the interventionalists will tell you if they're massive, you probably want to give them systemic lytics. Don't worry about it. I can still do whatever I want to do down the line. Most cardiothoracic surgeons will tell you the same thing. Go ahead and give the systemic thrombolytics. We'll see how they do. And then if we want to move on, that's fine. So we're going to do it. But, what dose do we give? It's like the big thing that we talk about. Like, at this time, I had alteplase. So should I give a full dose of alteplase? Should I give a half dose of alteplase? Should I give it as a drip? Should I give it as a push? What would you guys recommend?
I would recommend giving it as a push so that it's finished by the time I get there and we don't need to worry about switching out the tubing.
Like pushing down the ambulance ramps, like, I'm done. Peace.
Well, I'll say, this is obviously it's a big moving target. Let's just all be clear here. This person is a massive PE. They are a high risk PE. Every guideline would tell you that this person needs thrombolytics. And as long as there's no major contraindication to this person, they could get full dose thrombolytics and that would be okay. That being said, there is more and more data coming out saying that perhaps that is too much. And you while that is an okay dose to give somebody, you are increasing the systemic side effects. And the ones we're really worried about are bleeding in non-compressible sites like the brain and whatnot, right? So let's just start there. The PIA-PET trial, which was a small study, 23 patients. They had all patients were in cardiac arrest or peri-arrest, as I recall. They all got half-dose lytics, and none of them had any complications or sequelae of that. So you could use that as a model and say, well, half-dose would be okay. And the other thing I want to say is that you can also use much smaller doses, and you can always give more. That's the other thing that I think we're starting to explore in the research. It's like you could start off with a quarter dose or some fraction of the total dose that you want, assess how the patient's doing hemodynamically and give more, because we know that the person who has that massive PE, their biggest mortality benefit of thrombolytics is the first 24 to 48 hours of instability. So you have that time, as long as they're stable and they're not coding in front of you, to layer on the thrombolytics. But I would talk to people locally. We don't want anyone to watch this and say, like, well, I saw on a podcast on the internet. We want people to go locally, and these pulmonary embolism response teams, these PERT teams, are starting to pop up all over the place, where people are thinking this out, and you don't have to sort of carry this decision on your own. If you have a team available, if you have an intensivist and you're working in the ER, talk this out with your intensivist and come up with a decision together. But to answer your question, I think giving some fraction of a total dose of thrombolytics would be absolutely indicated for this person, because they're so unstable and they can't go anywhere else. And then later on, they can always go for some debulking if there's still clot left over with interventional or cardiology, whoever does that in your hospital.
Steve, you have a dose that you'd reach for here, or kind of the same thing? I'd talk with my local team and decide.
I'm kind of lazy. And so we've switched to TNCase for pretty much everything. Stroke, we're saving some money, which is great for our system. TNCase is so easy for me because I don't have to try to figure out boluses and drips. So even when I had alteplase readily available, I really like TNCase for PEs, and maybe it didn't hit as fast, so maybe alteplase was a better option. But when you look at the literature that's coming out, the opinions that are coming out, it seems like every time I hear something or read something, everyone's talking about going lower and slower. So some people, especially not these big ones, but I've seen stuff for some of the submassives doing like half dose over 8 hours and crazy stuff like that. So it seems like the trend is to go lower and slower. Pre-COVID though, I was let me just give them 50 a TNCase. I can bolus the whole thing. I don't have to hang a drip. It makes it easy. I can bolus it and I can cognitively offload it. That is done, and move on to something else.
I mean, if this patient was arresting, I think we all agree, full dose, and let it go, right? Because they're already dead. I'm not going to make it worse. This patient had no contraindications. Like recent orthopedic surgery, not a contraindication, right? No spine surgery, no brain surgery. So I didn't really have to think about that part of it. And again, this is a while ago. So we ended up with half dose, but gave half as a bolus and half over an hour. So I gave her 25 as a bolus and 25 over an hour.
Was that half of a half?
Not really having any real reason.
You did half. So you did half the dose, but you gave half of the half first.
Yeah. So I gave a quarter as a bolus and a quarter over an hour. And I kind of had the same voice in my head. I don't know if it was Haney's or somebody else is saying, you can always give another bolus. So if you give 25 and then 15 minutes later, 20 minutes later, you're like, I still don't like how she looks, you can give another 25 bolus. But if I give 100, I'm stuck with it. So we did 25 over an hour, and she did great. And so I'll kind of wrap up the case so we can move on to other stuff. We gave 25 over an hour. After about half an hour after the first dose, she looked considerably better. We were starting to wean off some of that norepinephrine. So clearly there was some impact of that thrombolytic. And so I called the ICU for admission. I'm giving handoff, and they were like, oh, this all sounds great. Would you mind getting a CT scan before you send her up? And I'm like, oh yeah, I should probably get a definitive diagnosis for you guys. So they were totally in agreement. They weren't like giving me a hard time, but they're like, it'd just be easier if you roll her through CT on her way up to the unit. It'll just make our lives easier. I'm like, yeah, no problem. But she did great. So she stabilized over about 24 hours. She didn't end up needing any additional therapy. They were, they consulted IR, they consulted cardiology, and they're like, she looks great. So let's just leave it. If she ever needs any more pressor, or she looks like she's decompensating in any way, then we'll take her for IR. But she did wonderfully. She went from the ICU to the floor in 48 hours. And then she was back at the rehab facility about a week after that. They kind of kept her for a little while, just making sure that they had, the right medications for her to be on. But she did fantastically well. So, there was like so much in here aside from the actual diagnosis that I thought was interesting in terms of what dose are you using, what pressors are you reaching for, when are you deciding to give those thrombolytics, and that idea of the pulmonary vasodilation with inhaled nitroglycerin, I think, is a big one for us to kind of have in our back pocket, not just for these patients, but we now have some pulmonary hypertension patients that are served in our clinic, and they come in with hypoxemia, and you give them inhaled nitro, and they do really well with that as well. So, I think it's a good little trick to have ready to go.
This is awesome. Really good case. I'm just going to go over some of the highlights. You have a patient that's rolling in to you with your pre-hospital, and it looks like a setup that they could have a PE. Like Mike said, just give them little aliquots of fluid to resuscitate them, and think about if there is the possibility of PE, if you can get away with it, not intubating that patient, because that positive pressure is going to be harmful. We talked about how to give them some good perfusion by what vasopressors to use. To pause and take a think about, could this be some inotropy that the person needs by using something low dose epi and seeing what happens, and then to do something that would be an afterload reducer for the pulmonary vasculature. Inhaled nitro, milrinone is just for academic purposes, but I think inhaled nitroglycerin is going to be something that's practical that everyone can use. And then really considering thrombolytics, again, it's a scary thing to think about, but this person right here is where the guidelines give you full permission, so you can always default to that. And then when it comes to what dose to use, that's something a little more nuanced that, we can't give a blanket answer for everybody, but look at the patient in front of you and see how risky it is for them to have intracranial hemorrhage, some of the other complications. If you like what you see in Morning Report, then you are going to love the ResusX conference. It is our 3-day resuscitation experience. It is unlike any conference that you've ever seen or been to. Short format lectures, high energy talks, debates, demos, games, prizes, ridiculousness, everything for 3 days. We're going to be doing this in Philadelphia, September 29th, September 30th, and October 1st. We have world-class educators, including the 3 people here on Morning Report, and so many more. So go to ResusX.com and register today. We have early bird tickets, although by the time you see this, they're probably sold out. But go check it out, and I look forward to seeing you in September. Now back to Morning Report. Boys, we are very lucky that we have job security, because people do some stupid stuff. And if you're like me, I have the maturity of a 5-year-old, and I love to see social media clips where people are doing stupid things. You guys up for it?
Oh yeah.
Of course.
All right, Steve left. I think he's too mature for us. Oh no, there he is.
I was scared. Sorry, I was scared.
All right. So these clips were submitted by all of you, and me. I'm going to be anonymous about it. Forgive my laughter. Now, by the way, This is what I tell my wife, because every time my kids and I watch these videos, my wife gets very upset. She's like, these people could have been legitimately hurt. And I assure her that because it's on the internet, everyone is okay. No one got hurt. And they put this up there just for laughs and for our entertainment. So here we go.
Whoa! To get this car up in the air, you want to drive me something hammer? Oh!
In case you're questioning my judgment in buying this instrument, this fine instrument made in America, it does have a...
Okay. Make sure it's all low.
Make sure it's on low.
Does he get back up?
That's not funny. No, that's hilarious.
It's the internet. He got up and he continued to teach
fine.
a seminar on the Tesla. Is that a Tesla coil?
I think so.
All right. Well, yeah, he was all right. He was all right.
You've heard of CPAP and BiPAP, and if that doesn't work,
these guys
this is
are fast.
extreme PAP.
I'm supposed to have the best mustache on this show.
Oh yeah.
Sorry, man.
Get the speed check in a minute. Parts of the soapbox starting to come off.
Oh, I love these
36
ones, these,
kilometers an hour.
go-kart
Here we
races.
have the water.
He's gonna make
Flies
it.
through
No way.
there.
He's gonna make it. No
problem
problem.
there. Now we've got the
Mario, I
stair
believe in
set.
you, Mario.
Down the stair. Oh, look at that. Down the stairs.
CT head and neck.
That's a little for it.
Yep. Oh, these are everywhere.
Oh,
This
this
is
is gonna be
nice.
fine.
This is nice. Yeah.
what,
This
yeah, I
is
can tell.
what
lovely.
could go wrong?
The weird
A
gender
blowtorch.
reveal. It's gonna be okay.
Helium, right?
Hydrogen filled balloon.
Oh.
What? I don't. But was it a boy or a girl?
It was Satan.
Is the
Oh, I see.
operative.
Was. No, it's the internet.
That's the musical version of the Hindenburg.
Yeah.
Like that was the school play.
Hindenburg on Broadway.
What?
Oh.
Let's go check it out.
You have an LLC.
At the lawn.
Oh, my kids or I
Where's
have
that
Listen,
done
freeze
job
on?
security is important. This is a
Yeah.
tough economy right now.
75% of those. Either myself or my kids have done. So that's how I know. That's why I can laugh.
Were you wearing Lululemon pants like the lady?
You've heard of CPAP?
Wait.
Get the speed check
Wait,
in a
did I
minute.
get them all? I think we got them all. All right, so there you
Orange is still my favorite because there's no good reason to do that.
Which-
Everything else, I'm like, I understand what this person was trying
Yeah.
to do.
Right.
Yeah, which one did you say they had?
The orange,
The orange,
and the drill.
yeah.
There's no reason to do that. Why
I
would
couldn't
you put a
figure
drill in
out.
a citrus fruit?
Maybe it's orange juice, like fresh orange juice, like yeah.
They have squeezers for that.
That's not how juicy
Yeah.
it is.
Yeah.
Yeah.
I do want to do a soapbox race at ResusX this year. Can we do
Oh,
the
yeah.
hill and build our
Yeah.
cars and
We definitely
Yeah.
we should have people bring their own clips. I think that would be hysterical. Oh, yeah. Now, speaking of ResusX, Steve, you got some good swag in the background. What are you getting into these days? Is it printing?
So
What's it
everything.
called?
I have unmedicated ADHD and doctor money and a lot of free time. So playing around with my 3D printer, got some light boxes here, some Hey Steve MD light boxes there as well. Get another one right here. We're gonna get some of those wired up, put some LEDs in them, and send them out to ResusX.
That's amazing. That's amazing, Steve.
That's
Thanks,
awesome.
thanks for doing that. And for anyone who is thinking about coming to ResusX, it's this September 29th to October 1st. All of these fine folks that you see here, plus many more, are going to be there at the conference. If you have not been to a ResusX before, just know it is not like any conference you've ever been to. It's educational, it's fun, short format lectures, and very ridiculous, like a healthy dose of ridiculous mixed in. So it's going to be a lot of fun this year. So hopefully you all can make it.
Can't wait.
Yeah, let's go to the final portion of the show, and this is really my favorite. So let's roll the intro. All right. And so what this is that we are going to go rapid fire through some topics, and Swami, Mike, and Steve are just going to go around. You're going to have 2 minutes to debate your point. You don't need 2 minutes. If you can state your point in a sentence, you could be done. But I'm going to present to you a question. You're going to go through and debate it. You got 2 minutes to do it, and then we're going to go on. And please be unhinged and unacademic as possible. You guys ready? So the first one I'm going to ask you is, there is a ton of data that has come out suggesting that people should be using bougies, not only for difficult airways, but possibly for every airway. And for people who are airway snobs, you couldn't find people who disagree with this more. It's like, oh, you don't need a bougie, this and that. And it's like, well, here's the papers, here's the data. And they're like, yeah, that's whatever, you don't need it. So my question to you all today, since you are all very facile and teach airway, is should we be doing bougies for everyone? Swami, you're up first.
Bougie every time. The data is quite clear in expert hands. Bougie improves your first pass success rate. I'm going to use a bougie every time, and it's not because I own the largest manufacturer of bougies in the country. That's not why I'm pushing it. I think anybody who is not going bougie first is in denial about the terribleness of their skills, and that's the bottom line, right? Because if you intubate 90% of the patients that you see on first pass, that feels really good. 90% first pass success rate, not acceptable. We need much higher than that.
All right. Mike.
Yeah, bougie every time. I tell the students, you use a bougie first line, everything Swami said. That being said, I have started using a rigid stylet occasionally, and I do like it. I think if you're using a hyperangulated VL blade, a rigid stylet is a little bit better than the bougie as far as the geometry, but unless you're using that, yeah, bougie every single time. I was a medic for 9 years before I used a bougie, and the first time I used it, I only used it because it was hanging out of the airway kit staring at me. I said, let me give this thing a try, and I said, why the hell have I not been using this thing the entire time?
Perfect. I got to be the contrarian, so we'll just be a contrarian to be a contrarian. So you've got to do something every time. You've got to do the same thing every time. You've got to be prepared for that nightmare airway every time. The average ER physician does 10 intubations per year. You've got to do that 10 times a year to be proficient at it. So if the bougie's your thing, go with the bougie and do it every time. So you're doing those 10 airways a year with the bougie. But if you're going to do hyperangulated with the rigid stylet, I agree with you, Mike. If I'm using hyperangulated, I'm using the rigid stylet. Get good at that. Get good at your one thing. If you're an anesthesiologist and you're tubing 10 people a day, sure, do one bougie intubation a day to stay proficient with your skills. For me, I'm a bougie first kind of guy. I use the standard geometry video laryngoscopy blade with a bougie on it, my tube preloaded on it, because I know that bougie has saved my tail many times. And I need to be proficient with it. So if I get in a situation where I have to have it, I'm really good with it. I'm familiar with it. My staff are used to it. And so I'm doing bougie first every time. But if you're a hyperangulated guy with a rigid stylet, not my cup of tea. I like that DL blade. I like to be able to see things because that's what I grew up with. Get really good at that. If you're only doing 10, 15, 20 tubes a day, get really good at an intubation technique that can be done on everybody. Your easy airways, your difficult airways, your anterior airways, and even your contaminated airways, which is why I like that standard geometry VL blade. I tried to be contrarian, but I think I ended up just agreeing with all y'all. And I got 15 seconds left. You can have that sign back, everybody.
I was really hoping that someone would go to time so I could just ding them out and just swap the screen. So hopefully we'll get there. All right. Another thing that comes up quite often in trauma centers is the carrying whole blood in pre-hospital settings, whether or not we should be doing it, should we not do it, is it worth the resource? This is something actually, if you follow Mike in his podcast, Mike, give a shout out to your podcast.
Thanks. It's the world's okayest medic podcast.
It's a wonderful
on
podcast.
Spotify, Apple, all platforms.
It's more than okayest. It's awesome. But this is something that I've been following on his podcast for a little bit because there's quite the controversy to it. Maybe not so much for us in the hospital, but I'm just going to turn it over to you guys and let you go first. So, Steve, what do you think? Pre-hospital blood?
Ooh, blood pre-hospital. I'm going to try to be a contrarian if I can, but I'm going first, so who knows if I am or not. Sure, your big urban centers, NYC, you're given lots of blood pre-hospital. You have lots of opportunities. You can use it. Sure. I live down in the sticks. I live in rural Mississippi. We have, our population, our county population is 30,000. And our surrounding counties are even smaller than us. And so I've got to think about what's the best way to use my resources. Where should that blood be kept? And if I have it on one truck and the next county over and the county on the other side needs it, they can be at my center before they can be at scene with that blood. Now, our helicopter services have blood on them, and I love that. I love that our helicopters have blood because sometimes they go way out in the sticks, and we can deploy them to the scene on these nasty traumas. But for me in rural America, I don't think it's practical to keep whole blood on an EMS truck because by the time we could get that blood to the scene with most of these patients, they can grab and go and get them to my shop, or they can get to a major trauma center where there's more than just 1 or 2 bags of blood.
Ooh, all right. Swami.
I mean, I agree. I think it's a matter of volume. You really got to look at your trauma population. How often are we giving blood, or how often are we in situations where we would give blood? And if you got enough of those, then you should stock it on the ambulance. There's no reason not to start a whole blood transfusion while you are bringing the patient to the hospital. Giving fluids to patients who have trauma and have blood loss makes no sense unless that fluid is red. So I like this idea, but it's exactly what Steve said. You really got to know how often are we going to be reaching for it. Having it on your helicopter totally makes sense. But if you only have like one penetrating trauma a year that you would give blood on, then maybe it's just not the resource you need, and you just need to get the person to the hospital as quickly as possible.
All right, great. Let's go on to our next topic. Oh, no, I'm just kidding, my guy.
You didn't ask Mike. You didn't ask Mike.
No, I know.
The expert on the topic.
Yeah. No, I purposely skipped it because I know it's boiling his blood.
Yeah, no pun intended. I actually agree with you guys that resource allocation is key. Do I think that every EMS unit in the country needs it? No, because it's going to go to waste, and it is a precious resource. That being said, I would look to the Broom study. It's Broom, Duchesne, Mark Peel was one of the authors. There's tremendous data coming out of New Orleans to show that I think it was 11% less intubation, better GCSs. I think there was around a 10% increase in mortality with each minute that patients in the pre-hospital environment weren't getting blood when they were in hemorrhagic shock. So resource allocation is key, but yeah, I mean, it is showing that there's data to support it, but I personally have experienced patients where the last time I gave it, I had the cop on scene say, "Hey, do I need to call the fatal team out for this?" And I went like this, like that. We gave the guy a unit of blood, and he is alive and well right now. And I think, 2 years ago, we never would have delivered this guy alive. There are some publications with some big names that are very anti-pre-hospital blood, and I would shamelessly plug my podcast to listen to my episode on that. There is a financial and ethical conundrum at play with the naysayers to blood.
Do you remember the podcast episode that so people can reference it?
I don't remember it was. It's also not for the faint of heart, so listener discretion is advised.
Well, we'll put it in the show notes for sure.
Thanks, Mike.
All right, let's go on and talk about something that is, I think, controversial. And this is whether or not when you have a patient who comes in who's neurologically afflicted, whether that's hemorrhagic stroke or status epilepticus, and you're going to RSI them, what should be the paralytic that you use for intubation? Is it going to be rocuronium and saying that you'll get your neuro exam back later whenever you did, but the person you need to have optimal conditions for intubation? Or would you use something like succinylcholine so you can get your neuro exam back rapidly? Let's go with Mike first.
I'm going to use whatever I have in the drug box. So I really, I did really piss off a neurologist in a neuro ICU one time when we had to use rock, and he was very angry. And I said to him, "You act like you're not going to put this patient right through a CT scanner." Yeah, that's what I got.
Love it.
I have made a little shift over the last few years. I'm using more sucks than I used to use. I like it in my neuro patient. I do like the neuro exam. I don't know that it's going to change a lot. The biggest thing is I don't want them to be awake. I don't want them to be aware while they're paralyzed. And for most of your patients, if you're concerned about status, regardless of what their body is doing, you should probably be getting a stat continuous EEG. However, I work in rural America where I can't get a stat EEG at 2 a.m. And so my physical exam on the patient is all that I'm going to have. I still like rock. I grew up with rock. I have a soft spot in my heart for rock. But especially my status patient, if I can't get that stat EEG, I'm probably going to get sucks. And a lot of times when I'm standing at the head of the bed, I don't know logistically if I can get that stat EEG. And so let me just give sucks, because that may be the only seizure monitoring that I have is my physical exam. And if something happens, we need to do some testing, we need to do some lines, and I really need them to be still, I can give a longer acting paralytic after that. But especially in status, I have moved to more acetylcholine.
I already know what Swami's going to say because he's a big acetylcholine fan. So,
huge. I mean, listen, Haney and I are published on why rock is the better drug.
Now that's
we
a
have
flex.
Been clear about this.
That's a flex.
This is one place, not the flex, but this is one place where I do have a little bit of consternation in my head because I want to get that exam back as quickly as possible. I don't have Sugamedics readily available to reverse, so I kind of take all that into account. But I still come back to, I want to use rock because rock gives me optimal intubating conditions. It gives me a longer time of safe apnea. And while, do I know that an extra 30 minutes of paralysis is going to be the kicker on this patient? No, but I know if their SAT drops, that's bad. So I'm still going with rock, but I do have some real consideration for sucks in this case as well.
Nice. Well done. All right, let's go to the last one. And
Haney, I'm sorry, I have to drop off.
No problem.
I thought I'm a little behind. I didn't realize it was that late.
It's
sorry,
all good,
man.
brother. We'll catch up with you.
Last one.
No worries. All right.
Yeah, sorry guys. It was great seeing y'all.
Great seeing you, Swami.
I'll act as Swami.
Sorry, Haney.
No worries. I'll be Swami for this last one. All right, here we go. So
Perfect.
the last one we're going to talk about is teaching tubes. So, many of us are not only performing airways, but we're also teaching students on how to do it. So I'm going to go through, be Swami, but the question is should you be teaching your intubation skills for the novice learner? Should you be using video laryngoscopy or direct laryngoscopy? And for clarity here, we'll say that this is standard geometry in both senses, because I think most of you will agree with me that hyperangulated is a skill set in itself. So video standard geometry, direct laryngoscopy, what are you teaching your new learners on how to use it? Oh, it looks like Swami's up first, so let me go ahead and let me pop myself in there. Look at me.
So I'm published on this paper, and what I say is...
Look, I'm going to keep this very, very simple. I think that if you are teaching somebody who has no idea how the anatomy looks like from the inside, I'm going to be teaching them with video laryngoscopy all the time. And there's a couple reasons why. The first reason is that both of us can look at the screen together. So I don't have to worry about what they're looking inside or having them lie to me when they say they know what the RE epiglottic folds look like. I can see it on the screen, we can look at it together, and we can teach the anatomy as we go. Also, if they have no clue what they're doing as their first or second intubation, I'd like to be able to see where we're at and then be able to take the tube rather than waiting for a first, second, or third attempt that was failed. That's all I got.
I'm a field training officer, so I get the paramedics when they come out of school. They should already know how to DL somebody by the time they get to me. I am teaching them VL every time because it is the quote unquote, I think it's an overused term, but it is the standard of care. The data is clear, better first pass success rate, better intubating conditions. That's what it's all about. And if I hear one more EMS provider say, well, what if the batteries go bad? Or what if you have a power failure? I'm going to scream. EMS, they all want POCUS. They want the monitor, all the toys. But it's this VL thing that they're worried about, a power failure and nothing else. But I am VL first time, every time. But they better have their DL skills on par.
Right on.
Just in case as a backup.
Love it. All right, Steve.
So I don't want to agree with everybody. I'll try to be contrarian if I can, just a little bit. So first of all, I completely agree with Mike. If you're in a situation where your VL blade stops working and you don't have a backup, that is a failure of your director. That is a failure of planning. These things are so cheap now. These things are so readily available. I've got 2 that sit in my sim lab that were given to me for free because they were just extras. This is not, 1995 where there was one in the entire system. you should always have a primary and a backup of a VL blade. It should always be readily available. However, when I'm training, what do I train my learners to do? And I do what Haney does. When the first few tubes, we're both going to be looking at the screen and we're going to be looking at everything. I'm going to be teaching you the anatomy, making sure you know what you need to do. And then after that, once I know you know your anatomy, you know how to do epiglotoscopy, you know how to get down there, I'm turning the screen away from you and I'm teaching you DL. Still hooked up to the VL blade. I'm looking at the monitor and I see what you're doing. And if you get into trouble, I'm turning the screen back around for you. But I think DL is a skill that has to be learned, and it's not for equipment failure. It is for that really bad contaminated airway where you lose your camera. You're gonna be in that spot at some point in your career if you have it. And if you have never done DL, if you've never directly looked at those vocal cords without this screen beside you, you are going to be in trouble. So when I train, yes, my first few, we're going to look at the screen together. We're going to learn anatomy together. I'm going to teach you epiglottoscopy. I'm going to teach you how to get in the vallecula. I'm going to teach you how to expose the cords. We're going to make sure that we know the same things. But once I know that you have that down, the screen is getting turned away from you, and you are going to learn with your standard geometry blade how to do a good DL intubation. And if you get in any trouble at all, if you're struggling at all, I'm going to turn your screen back around, and we can use that to get the tube in. But I think you have got to know how to do DL for that contaminated airway where you lose your camera.
I love it.
5 seconds to spare.
All right, let's get us all up on the screen here together, and we'll take Swami out. Yeah, I mean, we're done with that segment, but I do like that approach. You know, start off with VL where everyone's learning together, and then you're graduating to DL. I think it's a skill that everyone should know how to do when they get into trouble, but I think it's one of those things you really have to have a mastery of the anatomy before you get there. All right, guys. So listen, that was a great first episode of Morning Report. Thank you all for being here. Really shout outs to all of you. Just definitely go check out Mike's podcast. Mike, it's the okayest medic podcast. But
the world's okayest.
The world's
medic
okayest.
Podcast.
But
yes, sir.
Give everyone your handle on social media that they can follow you.
It's Okay Medic Podcast.
Gotcha. And Steve, what are you promoting besides your 3D printed models?
I'm promoting happiness, goodwill, friendliness. Let's just be kind to each other. I'm on social media. I don't make any money or anything off of it, but hey, Steve MD.
Me neither.
Yeah. Hey, Steve MD. Yeah, Mike's content is great. We're doing this because we love to teach, love to educate, and we want to improve patient care for everybody. So we don't have sacks of money that we're carrying away from this, but check us out, give us a follow, and give us feedback.
Thanks. And then for me, you know, all I gotta say is I want to see you at ResusX. So go to resusx.com, check out the website, check out the lineup. It's our finest year. And this year we're doing it in an amazing venue that's going to be a whole lot of fun. And these gents and a lot more people are going to be there. So with that, I'm going to sign off. We will see you on the next Morning Report. Look for it. We're going to be advertising it. We'll have a brand new bunch of guests, but we'll definitely have these guys back on again because it was so much fun. Thank you all for being here. And Swami, the empty box to the upper right-hand corner. Thank you. And sorry you couldn't finish with us. All right. Take care, guys.
Thanks.